This presentation is about the 25-year history of professional liability in pediatric ophthalmology and strabismus, the OMIC, or the Ophthalmic Mutual Insurance Company, experience. I've been a board member of OMIC for the past 13 years. And the outline of this presentation is we're going to give you the background, the reason for the study, who was included in the database, the statistics, and then I'll present a few case studies and present some lessons learned. What is professional liability or medical malpractice? Medical malpractice occurs when a doctor, through a negligent act or omission, causes injury to a patient. And whereas medical malpractice occurs around the world, medical malpractice law varies from country to country. The goal of this presentation is not to discuss the differences between countries in terms of how medical malpractice is handled, but to learn from a review of our cases what can help all of us improve the care we give our patients regardless of where we live. But it may be interesting to touch on the differences in how medical malpractice is handled in our question and answer session. Although there's some information regarding professional liability and some aspects of our field, such as retinopathy at prematurity, there's no report of comprehensive claim statistics in the medical literature regarding the field of pediatric ophthalmology and strabismus, and that prompted a review of this area. We had a 25-year database at OMIC, and our hope was that ophthalmologists could use the findings for risk management in their own practices and to improve the quality of care they provide their patients. We published our work in 2015 in the Journal of APOS if you'd like further information on this topic. OMIC, or the Ophthalmic Mutual Insurance Company, was founded in 1987 by the American Academy of Ophthalmology, and you must be an Academy member to become a policyholder. It's the largest insurer of ophthalmologists in the United States. We had about 4,500 ophthalmologists at the time of this study and have added about another 1,000 since that time. The inclusion criteria for this study was any claim classified as pediatric ophthalmology or strabismus is determined by the claims department. And we used the definition of pediatric ophthalmology as birth to 21 years of age, as done by the American Academy of Pediatrics. And we looked at this 25-year period between 1987 and 2013. There were 140 closed claims resulting from 117 individual cases. And I'll not spend much time in this session on the entity claims, except to state that they are medical practices which employ the physicians. And they're sometimes named in a professional liability suit. And a bit of terminology: plaintiffs are those who file the claim, either the individual patient or their family in the case of a child, and the defendant will be the insured ophthalmologist. This graph looks at the insured specialty, and you can see that on the left, most of the physicians were pediatric ophthalmologists. We also had some comprehensive ophthalmologists and retina specialists and so forth. Note the average age of the defendant ophthalmologist, 45 years of age, is in the early mid-career stage rather than being just out of training or at the end of a career. We found that older ophthalmologists tend to be more conservative and may no longer be doing surgery. The plaintiffs, those filing the suits, were young by the nature of this study. Those older than 21 were, by the inclusion criteria, all adult strabismus cases. Strabismus claims, as you can see in this graph, were the most frequent, followed by ROP and trauma. So if we look at clinical claims, we look at frequency, the volume, how many claims there were, and then we speak about severity in insurance. And then we're talking about the size of the indemnity payments made by the insurance company on behalf of the insured ophthalmologist. And whereas strabismus cases were the most common, the most frequent, ROP cases were the most severe, that is, they were associated with the highest mean indemnity payment. And QUIP, or CWIP, means closed with indemnity payment. That is to say, for example, under ROP, that 50% of ROP cases were closed with an indemnity payment on behalf of the insured ophthalmologist. Most allegations fell into these three categories. They were treatment-related, surgery-related, or diagnosis-related. And of claims closed with an indemnity payment, 41 of 119 involved individual physicians, and 3 of 21 involved entities or their practices. Most cases were actually settled by the insurance company on behalf of the insured ophthalmologist, with relatively few actually going to trial or mediation or arbitration. It took on average about 2.5 years to close a claim once it was filed, but some went on as long as over 11 years. And not all claims, of course, have merit. In 62 claims, our expert determined by consensus that there was no breach of the standard of care by the insured ophthalmologist. "41 claims, or 35% of all claims, had an indemnity payment. The average was $473,851, with the highest being $3.375 million, which was an ROP case. And these were the 8 cases with an indemnity payment of $1 million or greater. As might be expected, most involved retinopathy of prematurity cases. And the final case involved a patient who, in retrospect, likely had symptoms suggestive of a carotid artery dissection in the preoperative period, who went on to have a completed stroke about 4 hours after an adjustable suture was performed. As you can see in this slide, that system issues where the liability extends beyond a single individual were involved in many cases. And what are some examples of systems issues? The most common was informed consent. Follow-up care was second. Identification of the surgical site where the incorrect eye or incorrect muscle was performed, and telephone care. A summary of our statistics is that claims in pediatric ophthalmology and strabismus are relatively low in frequency at OMIC, but high in severity relative to all of the claims that we see. And among clinical conditions, strabismus claims had the highest frequency, but ROP claims had the highest severity. And systems issues were commonly a factor in both claims frequency and severity. Now we're going to look at 6 case studies, which I've pulled out of this study, and learn some risk management recommendations from each of these studies. So these will involve a case of an orbital fracture, one of strabismus surgery, one of a corneal ulcer, a 4th follow-up after cataract surgery, 5th trauma, and 6th retinopathy of prematurity. So what in general should we be thinking about in thinking about the statistics I just reported? Well, those clinical conditions with a high likelihood of indemnity payment, we want to pause when facing these conditions. Perhaps consider longer appointment times, having patient education materials available, explicit goal setting and prognosis management with the patient, and patient support groups. And if a patient support group is not available, perhaps having that patient or their family talk to another family or individual who's had the same condition. And then we want to think about those vulnerabilities, those processes that lead to patient harm and significant payments if not managed well, in areas where implementing patient safety strategies can make a real impact. So our first case is that of an orbital fracture. And the case summary here is it was a 5-year-old boy who was fighting with his brother. His face was pushed to the floor and was rubbed against the carpet. The trauma was not actually witnessed by the parents. It was seen by the insured ophthalmologist on day 2 and diagnosed with a corneal abrasion. On day 3, there were reports of increased pain. An examination under anesthesia was performed to rule out a foreign body. 4 months later, the pediatrician ordered poor eye movement in the affected eye, and a CT scan revealed an orbital floor fracture requiring surgery. The plaintiff expert, and the plaintiff expert would be a physician who's been hired by the plaintiff to support his or her case, that there's been a breach in the standard of care. So the plaintiff expert's opinion was that there was a failure of the insured to schedule a follow-up visit. There were no forced duction testing performed at the time of the EUA. There was no real suspicion of an orbital fracture, and that a CT scan should have been performed early, and that repair of the fracture would have been easier if performed in the first 2 to 3 weeks. The defense expert, on behalf of the insured ophthalmologist, said the positives were the child did not have a characteristic picture of an orbital fracture. There were no signs of trauma around the eye and no documented restriction of eye movements. Negatives, however, were that there was a failure to schedule a follow-up visit and a failure to check or document motility in the clinic, and no forced duction testing was performed on the exam under anesthesia. The case was taken to trial, and a plaintiff verdict was rendered for $127,760. What are the risk management recommendations for this case? This case involved problems with the diagnostic process, and you can see that over $1 million was paid on claims where the diagnostic process was felt to be an issue. So, looking at issues with the diagnostic process, there's help in the Academy preferred practice patterns, having clinical guidelines at the point of care, a trauma checklist, and corneal ulcer checklist. So let's look in this case at a trauma checklist. So this is a trauma checklist available on the American Academy of Ophthalmology website, and it makes sure that you don't miss key areas of the examination. So in a case of ocular trauma, the 7th item in that list is ocular motility, and it says it is important to assess ocular motility as there are chances of direct or indirect damage to the extraocular muscles. Extraocular muscle entrapment must be ruled out. The iWiki, where this information was obtained, is a very helpful site on the Academy's website if you haven't visited it before. So this claim alleged a delay in diagnosis. And why was the condition missed? Well, there were no characteristic signs, symptoms, or history, but the event was not witnessed. And we are, after all, dealing with a 5-year-old child who may not be able to explain diplopia. The expert suggested having the child follow a toy or light during the exam in the office, and pain persisted longer than usual for an abrasion. So in thinking about the diagnostic process, misdiagnosis is due to inadequate skill or knowledge in only 4% of cases, and cognitive errors are often the cause. So there's faulty data gathering and data synthesis, and shortcuts and rules of thumb are used, which may lead to a misdiagnosis. The framing technique refers to a bias that depends on how a patient's history and findings are presented. For example, you might have an obese female who presents with headaches, vision changes, and papilledema, and you jump to the conclusion based on the way I've presented that patient has idiopathic intracranial hypertension, but you don't consider what else might have caused the problem, for example, malignant hypertension. Obedience to hierarchy refers to the hierarchy within a team. So let's say you're a resident or a fellow, and the attending physician or the chief of pediatric ophthalmology thinks one thing, or your consultants think another, and you are obedient to that hierarchy. But you may actually have additional ideas, which may actually be the correct one. And then finally, premature closure of the diagnostic process. So think about that patient with papilledema that I mentioned, and you jump to the conclusion of idiopathic intracranial hypertension. Well, what else could it be? You really want to develop a full differential diagnosis. How about, could it be bilateral optic neuritis? Could it be hypertensive retinopathy? Could it be toxic optic neuropathy, diabetic papillitis, a brain tumor, venous sinus thrombosis, or intracranial hypertension secondary to some cause, say tetracycline, or leukemia, and so forth. What are some signs of a possible missed diagnosis that there may be a problem with the diagnostic process? Well, first, the findings are unexpected from what you are anticipating given your diagnosis. The condition is not responding to the treatment you prescribe. Your diagnosis doesn't account for all of the findings that you're seeing. And the comorbidity explains some of the findings. Remember, we talked about that premature closure of the diagnostic process in the patient with papilledema, where you jump to the conclusion of idiopathic intracranial hypertension, and multiple patient visits. So the patient keeps coming back and they're not getting better. All of these are red flags that could cause you to rethink your diagnosis. So what are some cognitive strategies you can use to improve your decision making? First, pause. Think, what else can produce these findings? And worst, what is the worst case scenario? Which tests are needed to rule this in or out? And then use the 5 Ds to develop, disclose, document the differential diagnosis. So risk management recommendations here. Start again. Obtain records from other providers. Read all the prior chart entries. Account for all symptoms and findings, and develop a differential diagnosis or redevelop one. And refer for a second opinion if you're still not sure. You want to include the patient in your healthcare team. Patient needs to know if the condition is serious and worsening. Give them written instructions for care and medications. Make sure they have a follow-up appointment schedule before they leave the office. Track the results of any tests that you order and consults that you order, and specific reasons they should call if they're having problems before the next appointment. Let's go on to the second case now, one of strabismus surgery. And this was a 51-year-old female who underwent strabismus surgery because she did not like the appearance of the strabismus. However, she was unhappy with the alignment and scar tissue after strabismus surgery. And revisional surgery was performed, that she was still unhappy and sought care elsewhere and filed a claim. The surgery was performed by a comprehensive ophthalmologist. The plaintiff expert alleged improper performance of surgery led to excessive scar tissue and continued strabismus with a poor cosmetic outcome, and that there was a lack of informed consent. The defense expert said that the surgery could be defended, though the plaintiff would still need scar revision, and there was no procedure-specific consent in the record, but the insured did document informed consent in the chart, including the possibility of diplopia and scarring. The patient did go on to have revisional strabismus surgery by another surgeon, and afterwards the case was settled for $10,000. Well, what are the risk management recommendations here? Well, this is a case where informed consent was an issue, and informed consent does play a role in many of the cases that we see. We're going to talk about the importance of having procedure-specific consent forms and where you can find those, having educational material, and again, patient support groups, or if not a support group, then having that patient talk with another patient who's had similar surgery prior to having their surgery. So informed consent, again, it's a major driver, strabismus and cataract claims. You need to explicitly agree with the patient on what your short and long-term goals are and explain any limits on the success. What other comorbidities do they have which might limit the outcome, and that there may be a need for separate or additional surgeries. Informed consent is much more than having the patient sign a consent form just prior to surgery. It begins by cultivating a relationship with the patient. So you've got to cultivate the relationship and ask, what does this patient want or need? Ask the patient, what do you think is wrong? What bothers you the most? How do you use your eyes, and how is surgery going to help that? What do you feel should be done? What's the best timing for you? And what is your goal for this surgery? And then you want to cultivate understanding. Decide how much this patient knows or believes they know about strabismus and strabismus surgery. What do they think caused the problem? If it's back, why did it come back? How was it corrected the first time? Is it going to work again? How will this surgery help or not help? What complications might happen? Will more than one surgery be needed? And then resiliency. How is this patient going to cope if there are complications or residual problems? After surgery, some patients have double vision, at least for a while. Tell the patient that. How will this impact your work and life? Some patients need more than one operation. How will you feel if you do? Tell them this surgery may not correct all your symptoms. How disappointed will you be? Will the surgery still seem worthwhile? And then if you don't understand something or unhappy about something, will you be comfortable telling me? And then finally, you want to cultivate defensibility. So you want to communicate and document your goal and how you and the patient have agreed to define success, why another surgery might be needed, that there's a risk of diplopia, particularly in adults, and when another surgery might be done, and what can be done while waiting for second surgery. Use and give the patient a copy of a procedure-specific consent form. These are available for many procedures on the OMIC website and are much more helpful than a generic consent that says the risks and benefits of surgery were discussed. List there that this may not correct the cause of the strabismus. You may not get a perfect cosmetic result, or it may not correct diplopia in all gazes. Double vision may occur, or it may recur, and it may not resolve. You might need additional surgery. You might need eyeglasses with or without prisms after surgery. And then risk avoidance. And this is asking your staff for their input. Ask them to watch for signs when they're working up the patient of a demanding personality or unrealistic expectations. And then tell that patient, I want my patients to be satisfied with the outcome, and I don't think you will be. Sometimes you just have to say, I'm sorry, I can't do your surgery. The next case is that of a corneal ulcer. This is a 2-year-old who fell into oily matter in the driveway. The patient was taken to the emergency room, and the doctor called the insured ophthalmologist on a Sunday to report a diagnosis of a corneal abrasion with an acute inflammatory response. The insured was leaving on vacation the next day and did not alert the office about the ER consult, and that the mother was told to bring the patient into the office the next day. Patient and family did show up in the office the next day. They did not identify themselves as a referral from the emergency room, and they reported the condition as conjunctivitis. But they were told at the front desk that the office had a policy of not seeing public aid patients. The patient was ultimately seen at a local children's hospital 2 days later by a pediatric ophthalmologist and corneal specialist. The child was diagnosed with a significant corneal ulcer, which led to a permanent decrease in vision. The plaintiff expert opined that there was a failure of the office to see the ER patient and a failure to timely diagnose the corneal ulcer, which was a breach in the standard of care. The defense expert's opinion was that the insured met the standard of care with the phone consultation with the emergency room, but that the handoff to the office was troublesome, and the office not seeing the patient was concerning, and the patient's decrease in vision did seem to be a result of a delay in care. This case did go to trial, and the corporation or the entity, the practice, settled for $1 million. The doctors were dismissed from the case. What are risk management recommendations for this case? Well, declining to see patients. Well, the consulting with the ER physician created a physician-patient relationship with a duty to provide ongoing care, even though the ophthalmologist did not actually see the patient. That ophthalmologist either had a duty to provide care or arrange for another physician to see the patient without delay that could cause harm. And with regards to the patient handoff, the insured ophthalmologist was leaving for vacation and knew he would not be able to see the patient in the office, forgot to contact the staff or partners. This was especially important in this case, given the financial policy of the office. With regards to patient handoffs, one study showed that 80% of medical errors resulted from inadequate handoffs. So develop a handoff process, and we'll call it IPASS here so you can remember it. The I stands for illness severity. So if you're getting ready to pass this patient off to someone else, you want to say, this patient that is coming in, I think is stable. There's someone that needs to be watched carefully or someone that's unstable. And then you want to give a patient summary. A is for action list, S is for situation awareness and contingency planning, and S is synthesis by the receiver. Did they understand what you just told them? So let's look at that example in this case. Hand off to another provider. I for illness. You're talking to your colleague in the office. This is a watcher. This is someone I'm concerned about. Patient summary. This was a 2-year-old that fell into oily material and was diagnosed with a corneal abrasion and treated with an ointment and patch in the ER. A, action list. I want you to see him tomorrow and check for infection or ulcer. S, situation awareness and contingency planning. If worse, refer him to a corneal specialist. If his mother doesn't bring him in, call her right away and send a letter. In synthesis, did the receiving physician understand the message? Okay, this is a 2-year-old with an abrasion from oil seen in the ER. You want me to check him tomorrow for infection or ulcer and refer him to cornea if worse. If he is a no-show, you want me to call his mom and send a missed appointment letter. Is that right? And then you want to do the same thing with the mother. I, we need to watch carefully. P, the oil got into Joey's eye and could cause a serious infection or scar. A, I need you to bring Joey to my office tomorrow at 9 a.m. Yes, if his pain gets worse, I want you to call me. Then the mother should respond that she's understood this message. Joey could get a bad infection. You want me to bring him to see you tomorrow morning at 9 a.m. If his eye pain gets worse before then, you want me to call you. Is that right? Our first case is follow-up after cataract surgery. So this was a 4-month-old male who underwent uncomplicated monocular surgery for congenital cataract. 9 months later, a comprehensive ophthalmologist following the patient in another town noted that pressure was elevated. He called the insured ophthalmologist who'd done the surgery, and he recommended therapy, which resulted in a decrease in the pressure. Then the patient was lost to follow-up despite phone calls and letters, and the family later filed a claim alleging the poor vision was due to improper surgery and management. The case was reviewed by a plaintiff expert who opined that the contact lens had not been used in this case. However, the defense experts said that a contact lens had indeed been attempted and that noncompliance was the major reason the child had problems with vision. The outcome, this case was eventually dropped and there was no further activity on the case. So what are the risk management recommendations here? This case has to do with follow-up systems, which played a role in many claims in this series. And we have resources at OMIC about the non-compliant patient, and later we'll talk about a case of retinopathy of prematurity. These are particularly important in neuro-ophthalmology cases that you may see where there may be vision or life-threatening issues, and you may be ordering tests or getting consultations and need to make sure you have a follow-up system for those. So follow-up systems involves a number of things: tracking test results, consults when you order them, following up on missed appointments, scheduling consults for high-risk conditions, and a phone contact form to the office following ER consultations to alert the office to expect a call from the patient. So here's an example of a follow-up system. So listing the patient, the test ordered or the consultation ordered, the date it was ordered, when you got the results, what kind of follow-up is needed, and when everything is complete. And if you have blanks on this form, it means you need to follow up. So you want to make sure you communicate the results to the patient, document your discussion in the record, file a report, complete a tracking form, and then advise the patient no further follow-ups needed, or you need a follow-up appointment on a certain date, you've been referred to another doctor, or you need another test. Our fifth case is one of a foreign body. In this case, a 10-year-old's parents reported the patient was hammering a penny in his garage and a fragment flew up and hit him in the eye. The patient flushed the eye. Next day, the patient was seen by the pediatrician, who noted decreased vision but found no evidence of a penetrating injury. The pediatrician telephoned the insured, who was on call for the local children's hospital emergency room. And the insured was advised of the pediatrician to refer the child to his office or to the ER if the condition worsened. The pediatrician spoke to the insured several days later to inform him the patient did not improve, did not go to the ER, but was seen by another ophthalmologist who diagnosed an intraocular foreign body requiring surgical intervention. The plaintiff's expert said that the insured fell below the standard of care and should have seen the patient after the phone call with the pediatrician, and that the lack of pain and negative fluorescein tests was a strong indicator this was not a corneal abrasion. That the pediatrician should have been advised this was an emergency and that the patient should not have been sent home. The defense expert said the insured met the standard of care if his version of the phone conversation with the pediatrician was accurate, but many defense experts were critical of how the pediatrician handled the situation in phone consultation with the insured. The outcome here was a defense verdict. What are the risk management recommendations for this case? Telephone care is very important and can cause problems in your practice. We have some resources on the OMIC website for telephone care. Well, does telephone care create a duty of care? The defense attorney filed a motion that the insured never saw the patient, had no relationship, but this was denied because telephone consultation does create a relationship and duty to treat that patient and follow up with him. So what lessons can we learn? Use a contact form to prompt questions. Verify all aspects of the exam by the physician in the emergency room. have a low threshold for seeing the patient, especially post-operative ones or in the emergency room. And inform your staff to expect the patient from the ER if you advise the patient to come to the office. You've got to credential the other physician that you're speaking with. Don't assume that they have the knowledge or skill to complete the exam that's needed. The ophthalmologist did not ask about how the injury occurred if a slit lamp exam was performed or about the vision. On deposition, the ophthalmologist said if he'd been given information about metal on metal contact, he would have deemed it an emergency. And this is our last case, one of retinopathy of prematurity. This was a premature infant born at 28 weeks gestation, 949 grams. The insured first examined the infant at 7 weeks and diagnosed zone 3, stage 1 retinopathy of prematurity and recommended a follow-up exam in 1 week. The hospital never contacted the insured for the follow-up visit, and the infant was transferred to another hospital 2.5 weeks later with no mention of retinopathy of prematurity. The infant was later diagnosed with bilateral total retinal detachments. The plaintiff's expert's opinion was that blindness resulted from failure to fall upon ROP. The defense expert said if the insured's initial staging was correct, then follow-up may not have been an issue. However, he believes the staging was likely not correct. And given the notation in the chart to follow up, the review was critical of the insured, but the insured didn't want to defend the case. The neonatologist expert opined they had no duty to inform the ophthalmologist of the follow-up visit. And this case was settled for $575,000 on behalf of the insured ophthalmologist. Remember, we talked about the high indemnity payments associated with retinopathy of prematurity. And we're going to talk about the importance of tracking with 3 people until the screening is complete. Having protocols and knowing the natural history of this condition and setting follow-up appointments. Systems issues we found in our study played a bigger role than did the clinical skill of the physician. So our risk management recommendations. A duty to provide ongoing care. ROP has a well-known history in national clinical protocols, and the infant is at risk until they've met the end of screening criteria. There's a duty to screen or treat, and that doesn't end until it is complete or there's a formal handoff to another physician. There were many missed opportunities in this case, and that's why it's a system failure. It wasn't the fault of just one person. Staff members sent a follow-up letter to the home while the infant was still hospitalized instead of scheduling an appointment. At the hospital for follow-up, the NICU never requested a repeat exam, and the neonatologist did not include ROP in the discharge note. The second hospital didn't assess the eye condition during the entire hospitalization. And the second neonatologist was told by the first one that the eyes were being followed by ophthalmology. They did not notice the absence of eye exams, and the ophthalmologist in question actually had no privileges at the second hospital. The office staff member did not notify the IMD, the ophthalmologist, when the infant was a no-show, but sent a letter. And the family did not respond to either letter, even though the grandmother was a nurse. So you've got to create a safety net. And that involves triple tracking by the NICU, by the ophthalmologist, and someone in the ophthalmologist's office. The ophthalmologist needs to be notified prior to discharge. The NICU needs to contact the outpatient ophthalmologist, and there needs to be a formal handoff from the ophthalmologist if the child's transferred before the end of risk period. Well, I hope you've learned some lessons from these cases that will help you improve the quality of care you provide your patients, and that you will implement some of the risk management practices we discussed into your own practices.